Hi, I'm Dr. Yoki.
And I'm Dr. Lu.
Today we're going to be talking about the biggest misconceptions and myths about psychiatry, and we're going to be debunking a lot of them. So stay tuned. One of the first misconceptions within psychiatry is that you're not a real doctor. Now, how many times have you heard this?
Quite a bit, honestly.
Yeah, I mean, when I was doing my major clinical year in medical school, I had residents just tell me, don't go into psychiatry, it's not a real field. And I don't know how many times I've heard that, and people trying to convince me not to go into a psychiatry, like if it was in their place to do so, first off. But first off, psychiatry is, yes, you're a real doctor. You go through medical school, you have to go through 4 years of training, and then you do residency. You can prescribe medications within psychiatry, and you can also even prescribe non-psychiatric medications if you're comfortable doing so. I know some psychiatrists who feel very comfortable managing like hyperlipidemia, diabetes, like all these other medical conditions that are very common within the patient population that they treat in psychiatry. So I don't know why psychiatry gets that bad rap.
I mean, just the other day I had a patient who was hyponatremic, and we had to do a whole workup in order to determine what level of intervention we needed to do and what interventions we could do on our end in order to make sure that the hyponatremia did not get worse. Mm-hmm. So even though people say that you're not necessarily going to use medicine a lot, you do use it more than you might think. It's not all just talking to your patients. Many of these medications can have side effects. And in psychiatry, you need to be able to both understand the side effects of the medications that you're giving and medically how to treat the side effects if they come up. So one of the other big myths in psychiatry is that if you're a psychiatrist, your patients will never get better. And that couldn't be farther from the truth. Depending on what studies you look at, say for example for schizophrenia, those with severe schizophrenia, anywhere from 20% to 70% of patients with schizophrenia will ultimately recover as long as they're placed on good psychiatric therapy and good psychopharmacological interventions. And many similar trends can be seen for depression, for bipolar disorder. Overall, mental illness is very treatable. And that's one of the bigger myths that's spreading around today, that if you're a psychiatrist, you're not really going to see any improvement with your patients and it's all terrible. That couldn't be farther from the truth.
And so there are these populations within psychiatry called people with severe mental illness, or SMI. And those patients are often in and out of the hospital. They're often not adherent to treatment or their medications. They're very difficult to keep within, an outpatient treatment program. And these populations of patients with severe mental illness, a lot of them, have a lot of other things going on that are making it very difficult for them to adhere to their treatment. So whether they're, homeless at the same time, whether they also have substance use disorder, whether they have something else going on. And so those populations are very challenging, and we're not going to, downplay that at all. There are definitely very, very sick patients within psychiatry, but even more reason why I personally love psychiatry is that you can make such a big impact within, these specific populations that have severe mental illness. And you can improve at least some functioning within that population. Whether that's, before you couldn't even go and go grocery shopping. Well, now if they're on treatment, they're, able to do that on their own. And little milestones like that make such a huge difference in a person's life. And it's what, for me, what gives me motivation within psychiatry to treat, patients with severe mental illness is you have the opportunity to improve at least some of their functioning if, they're able to, remain on medications and you're able to address these other issues that they're dealing with.
And kind of along the same lines, you'll find these sorts of situations in other specialties as well. There will be patients who don't take their blood pressure meds. There will be patients who don't take their diabetes medications. And it'll be for a variety of different reasons. But to single out psychiatry as your patients will never recover because they don't take their meds or because there just simply isn't the way to treat it, that's completely false. There are patients, for example, with diabetes who require chronic treatment. It's a chronic illness. And so long as you keep them on medications, they won't be cured, but they'll be at a level of functioning that they can proceed well. That's a very similar situation to what you see in psychiatry as well. The next myth in a very similar vein is that, if you go into psychiatry, you're going to get attacked by all of your patients, the patients are going to stalk you. And taking a look at the hard stats, residents in internal medicine or surgery had a 25% to 40% chance of being attacked by a patient throughout their residency. Those in psychiatry were anywhere from 25% to give or take 60% of being attacked by a patient while they're in their residency. So there might be a slightly higher chance for those in psychiatry, but it's not that much different than if you were to be a doctor in any other specialty. And of course, you have to break down that number as well. Where are these residents working? Are they working primarily in the emergency department versus are they working in an acute inpatient setting? So it really depends on what setting you're in. But the point being, you're not that much more likely to be attacked by somebody or by a patient if you're a psychiatry resident versus if you're a resident in a different specialty.
And there are ways that, residents get trained in how to minimize the risk of being attacked physically by patients because in the inpatient units, you are dealing with very sick patients that don't know, can't tell the difference between reality and their delusions. And so they might think that you are a part of this conspiracy and that you're out to get them. And so there is bound to be some, level of agitation in the inpatient units, but there are ways that you can protect yourself, and we get trained how to do that. We get trained on how to recognize the signs of agitation early on so that we can leave the room or get out of that situation before it gets to the point where the patient wants to get physical. I know personally when I'm in the emergency department, if I see a patient that says, that they're feeling really angry and they start to, for example, clench their fists in the middle of an interview, then okay, that's my cue that I need to leave. Like, thank you so much for sharing everything that you told me. I'm gonna go and talk to my supervisor and we'll come back to you and talk about the plan. And that's it. And I exit the room because you can't ignore those early signs of agitation, and they do happen. And you have to take them seriously. You can't just ignore them.
All that being said, the vast majority of patients with any sort of mental illness are not likely at all to be violent. So that's again another myth that really has no real basis in reality.
Now, the last myth that we're going to talk about is if you're a psychiatrist, you're never going to use medicine ever again. The reality is that when you're seeing a patient for the first time within psychiatry and they're coming in with either depression or a psychotic disorder, you need to make sure that that person doesn't have a medical illness that is causing these symptoms. You need to make sure that you rule out every other reason that isn't psychiatric for, their symptoms. So one example, I'm just going to give one example. If a patient comes to your office and they're complaining of, auditory hallucinations and visual hallucinations and they're not acting right. But what if this patient actually has like an encephalitis that's causing their auditory visual hallucinations? You need to be able to recognize certain signs and symptoms on the physical exam that will lead you to that conclusion that, hey, this is not a primary psychiatric condition. This is a neurologic condition. This person needs to go and see a neurologist, or this person needs to go see another specialist. You need to be able to recognize that very well, because you could be wrongly diagnosing and treating this person. And that is very detrimental. Obviously, no one wants to wrongly treat and diagnose a patient. So you definitely need to know your medicine. Also, within psychiatry, a lot of the medications have certain side effects that you need to know how to manage, and you need to know how to recognize and what to do about them once they come up. For example, antipsychotics can cause metabolic syndrome, which just means you have a higher likelihood of developing obesity, diabetes, and high cholesterol. Now, some patients with severe mental illness might not have a primary care doctor. You might be the only doctor that they want to see. And so you need to be comfortable, treating that. You need to be comfortable prescribing a statin or prescribing metformin or, managing these illnesses because you might be the only doctor that these patients see. There's a lot of patients within psychiatry that don't actually have a primary care doctor, and you should encourage them obviously to see a primary care doctor, but a lot of the times they don't want to. They feel comfortable with their psychiatrist. They have a really strong connection with you. And so you need to be okay with managing, things that you feel comfortable with. No one's saying that psychiatrists should treat everything and should, treat things that they don't feel comfortable treating just because the patient doesn't want to go to a primary care doctor. But, whatever they feel comfortable managing in terms of medicine, psychiatrists can and should be able to do.
And not only that, besides the fact that some of these medications can cause side effects and the patients may have more comfort with you as your psychiatrist, many patients with mental illness also have multiple medical comorbidities. So they're already going to be, even if you didn't prescribe it yourself, they're likely already going to be on a number of different medications that are not necessarily psychiatry related. You know, they may be on metformin, they may be on multiple antihypertensive medications, they may be on other medications that you as a doctor need to be able to understand. Are you seeing any changes in their mental status as a result of the medications they're on? Or is this due to their underlying medical comorbidities? And as a doctor, you'll need to be able to understand that, to identify it, and when it happens, to be able to manage this patient.
I hate hearing people say, oh, you're dealing with crazy people every day. That's what you do on a day-to-day basis. Mental illness is so common. I know so many people personally who have experienced mental illness, or I'm sure you know someone, or you know of someone's friends of a friend, or anyone who has experienced mental illness in the past, or you know, are currently struggling through a mental illness. So there's still stigma within society in that, you know, people with mental illness are considered like crazy. We don't use that within psychiatry. We don't use that word. We don't think, obviously, that people with mental illness are quote unquote crazy, because it's very common. 1 in 6 individuals in the US have had in the past or currently have mental illness, and it's very common. You might know someone who actually has mental illness, and you might not even know that they're going through that. I personally know so many people who have had it in the past and who are struggling still with it. And mental illness is a real disorder, just like any other medical condition that has its basis in biology and a pathophysiology to it. The same case goes for mental illness. Usually it's like an imbalance in a neurotransmitter, and that's just to put it very simply. It's a lot more complicated than that. Mental health disorders have a pathophysiologic basis, and they deserve the same level of respect and attention as any other physical and medical condition. So those are the most common myths within psychiatry. If you have any other myths that you heard of, please put it in the comment section below. Or if you don't know if it's a myth and you want to ask us more about it, just put it in the comment section below and we'll get back to you.
But otherwise, don't forget to like and subscribe, and we'll see you guys for our next video.
Thank you.
Bye-bye.
Bye.